Hello everyone, I'm really thrilled to be here. I'm Dr. Anna Duarte, the Division Director of Dermatology at Nicklaus Children's Hospital and the President, Founder, and Medical Director of the Children's Skin Center. And today what I'd like to talk to you about is why it's important to have early intervention in the treatment of infantile hemangioma. So this is our institute here at Nicklaus Children's Hospital, the International Birthmarks Institute. And I wanted to start off by talking about ISVA. ISVA stands for the International Society for the Study of Vascular Anomalies, and there's a classification of vascular lesions. So basically you have vascular anomalies divided into vascular tumors or vascular malformations. Today we're going to focus on vascular tumors and basically benign vascular tumors. And you can see there's a wide differential even just looking at vascular tumors and looking at benign lesions. But today we're going to focus on infantile hemangioma. This is the most common tumor of infancy, being found in 1 to 3% of newborns, and it's characterized by rapid proliferation or growth of endothelial cells and vascular channels. There's slow involution over many years afterwards. These are also GLUT1 positive, which is very important, and that'll come up in a moment. So I wanted to distinguish the infantile hemangiomas from congenital hemangiomas. Congenital hemangiomas are fully formed at birth. These happen to be GLUT1 negative. So if there's ever a doubt, a little biopsy with a special stain can distinguish between the two. But again, we're focused today on the infantile hemangioma. These have certain risk factors associated with them. Low birth weight, advanced maternal age, if the baby is a girl, Caucasian, if the baby's premature, if there's multiple gestations, and so on. Any kind of stressful hypoxic stress also predisposes the infant to having an infantile hemangioma. There's some theories on the pathogenesis. One says the placental origin suggests that the fetal progenital cells arise from the disruption of the placenta during gestation. There's also the endothelial progenital cell theory, where the circulating endothelial cells migrate to locations in which conditions such as hypoxia or developmental field disturbances are favorable for growth. And then there's the unifying theory, where these two come together, where the epithelial progenital cells migrate to locations in which conditions are favorable for growth into placental-like tissue. Again, these are hypotheticals, we're not really sure, but these are some theories that are proposed. So remember that congenital hemangiomas are fully formed at birth. Very important to get that history, because infantile hemangiomas, as I'm going to show you now, 50% of the case, and there's absolutely no lesion whatsoever at birth. And in the other 50%, there's a small precursor lesion, which could be like a little bruise-like appearance or a little anemic pallor in the area. So again, not fully formed at birth whatsoever. They can be located on the head and neck, the trunk, the extremities. And they can be distinguished by clinical type and morphologic type. Clinical types ranging from superficial, deep, and mixed, and morphologic, focal, multifocal, and segmental. Here are some examples of superficial lesions. We used to refer to these as strawberries. We no longer use that terminology. These are superficial infantile hemangiomas. They can also be deep. These are a little harder to make the diagnosis because sometimes it just looks like a bump. Sometimes we need an ultrasound to help us make this diagnosis in this case. And there's mixed, superficial and deep, as shown here. The same patient can have mixed, superficial, and deep. Here's some examples of morphologic differences: focal lesions, or one lesion, nice and localized, or multifocal, where you have multiple lesions. And then there's the segmental morphology, where you have large plaques of skin being involved. And we're going to talk a little bit about syndromes associated with this presentation in a moment. So when you have a plaque-like lesion, this is not usually random. They usually follow the developmental plaque codes of embryology. And these have a higher risk of ulceration, disfigurement, and association with certain structural anomalies, as we're going to review now with the Faces syndrome. So Faces syndrome is when you have a large segmental hemangioma. It's associated with posterior fossa malformations, particularly the Dandy-Walker malformation. And also hemangiomas. Because it sounds phonetically like face, does not mean it has to be on the face. It could be a segmental hemangioma anywhere on the body. So faces without face. You can also have arterial anomalies, cardiac defects, eye abnormalities, and also E for endocrine. These patients can have hypothyroidism, and they can also have sternal defects and other midline deformities. Some other syndromes associated with segmental hemangiomas, you can have the lumbar, pelvic, and sacral syndrome when you have segmental hemangiomas involving the buttock, the perineal, and the genital area. And these are defined as shown here. Lumbar, sacral, and pelvis are acronyms for lower body hemangioma, urogenital anomalies, myelopathy, bony deformity, anorectal malformations, arterial anomalies, and renal anomalies. In one case, they kind of all overlap, the pelvis with perineal hemangioma, external genitalia malformations, meningocele, vesical renal abnormalities, and perforate anus, skin tag, and so on. So the important thing when you see one is to think of these associations, and I usually work together with my urologist and nephrologist and even neurosurgeons, as some of these kids may have a tethered cord, when I see this presentation. Life-threatening presentations include the lower third of the face. A lot of times the airway will be involved, so when you see the beard distribution, think airway and have the kids checked by ENT. And also when you see multiple lesions, there's a risk of cardiac failure from having too many lesions in the liver, a high output failure type of situation. So in that case, you want to get an ultrasound of the liver, but also the brain and spleen are usually checked as well. These are areas that can also have hemangiomas associated, the liver being the most common organ to have hemangiomas associated. So here you have an example of a patient with the lower third of the face. Think ENT, think upper airway, intervene early. And here's a patient that in spite of early intervention required a tracheostomy. So just to remember this area of the body, think ENT, airway. You can also have a functional impairment because of location. So this is another key area to intervene early. So ophthalmology with a ptosis, these kids can end up with amblyopia if you don't intervene early enough. Here's an example of a patient with a large tumor in the orbit. Fortunately, the globe was pushed out of the orbit and this patient did rather well. However, you need to take action early. You want to get the patient treated before this kind of presentation. Also, functional impairment, think about the ear and the blockage of the external auditory canal and have ENT evaluate this patient, but intervene early to prevent this. And also, a lot of times we forget the breast is a vital structure, especially in girls. And so involvement of the breast blood can sometimes result in breast aplasia. So this is another time where you want to intervene early and not let this lesion proliferate. Remember, when the babies are first born, there's almost nothing there. So we want to get ahead of this proliferation. Disfigurement is also another reason to intervene early. If you let these lesions grow quickly and rapidly into their full size, you can get a lot of distortion of the normal anatomy. And one particular area that's key to intervene early is on the tip of the nose. Very difficult to reconstruct with plastic surgery. So it's important to get in there before this proliferation occurs. And here are some other areas that you want to intervene early. I can't emphasize that enough. Also, another common complication of these lesions is ulceration, especially the segmental lesions, as I mentioned. So intervention early can help prevent some of this. When you have a complete extremity affected, you may end up with a contracture. So you want to work as a multidisciplinary team with orthopedics, plastic surgery, and occupational therapy for these patients as well. So we talked about at birth there's almost nothing present. Now I've shown you proliferation, a rapid proliferation in areas where you want to take action early to prevent that disfigurement, to prevent life-threatening conditions, ulceration. Look at different syndromes associated with segmental lesions. So after this proliferative phase, what happens? There's a slow involution over many, many years, but that doesn't mean the lesion goes away completely. So you can see here, you have a patient over time, the lesion's very small, proliferates, and then involutes, but doesn't mean there's going to be normal skin at the end. This is the rapid proliferation, some more examples of that rapid proliferation starting from a very, very inconsequential lesion to a very large lesion. Here's another example. And here's a very dramatic example. The baby is born as a twin, and you can see the baby is almost nothing to write home about at birth whatsoever, and in a few months, look at how large the lesion is. So natural involution without therapy, 10% in the first year, 50% by age 5, 70% will go away by age 7, 90% by age 9. This takes many years. It's the entire childhood, formative years of these children, so we want to intervene early. I'm going to touch on this at the very end, but some of these kids will have psychosocial issues without treatment because of bullying and the fact that this is a very visible lesion in most cases. And we know that involution does not mean normal skin at the end of it. So here are some examples of the slow involution. Again, redundant fibrofatty tissue. So when should we treat? So this is the whole crux of the matter here. We want to intervene early, but when is appropriate? So we want to wait until at least 1 month corrected age, and then we want to intervene at that time. Because when you see the growth phase of this lesion, you can see it happens quite early. By 6 months of age, it's already fully formed. So you want to get it on that upward slope of this curve. So we want to treat early, and Hemangiomas is the first FDA-approved propranolol for infantile hemangioma requiring systemic therapy. It's first-line therapy. We've changed the whole treatment paradigm from the oral corticosteroids. In 2008, when this article came out in the New England Journal about the efficacy of propranolol, and then there was a big study, and it was FDA approved in 2014. So really we've shifted the treatment away from oral corticosteroids and really used almost always the oral propranolol for these life-threatening, function-threatening lesions that require systemic treatment. The mechanism of action is not exactly understood, and there's some theories that are proposed and how it inhibits the angiogenesis. It's extremely effective. So again, I mentioned corticosteroids are now second line. There are some topical medications that we can use, such as timolol as a bridge to systemic treatment, or adjunctive. This is not FDA approved. This is an off-label remedy treatment. We can operate, have scalpel excision of pedunculated lesions. We can intervene with lasers in very superficial or ulcerated lesions. But really, you want to use a combination of treatments and a multidisciplinary team approach. And at Nicklaus Children's, we have the International Birthmarks Institute, where we have a multidisciplinary team management for all of these cases, and we meet monthly to discuss patients. You can certainly send your patient over for a consultation. It's completely free of charge, and we meet again as a team and go over difficult cases. We can go over the imaging and give a consultative feedback. So at my practice, the Children's Skin Center, this is the treatment paradigm that we follow. So first, the patient needs to meet the criteria that it's an infantile hemangioma, which requires systemic treatment. And Pierre Fabre has recently released an infantile hemangioma rating score. So it's a tool that you can use to decide if you're unsure if a patient needs referral. I always feel that you should refer if you're in doubt and make sure the patient gets that evaluation, and perhaps the dermatologist or pediatric dermatologist can reassure you this is okay to wait. But it's always better to get a referral if you have any doubt, because again, early intervention is key. So we start at 1 milligram per kilo per day in 3 divided doses for the first week, provided everything is good. We go to 2 milligrams per kilo per day in 3 divided doses, then 3 milligrams per kilo per day. And I usually treat until the child is 18 months of age. But the minimum amount of time that is recommended to treat is 6 months. And of course, each case is individual and has to be evaluated on a case-by-case basis. So you need to emphasize giving the feeding with the medication with a full feeding. And also, we check the baby monthly and adjust the dose in case the baby's outgrowing his dose. And sometimes we just let the dose ride and have a natural taper. And again, treat until 18 months of age, which is when most of these lesions will plateau, and a minimum of 6 months. Now, some patients do require treatment for an extended period beyond the 18 months into 2 years, 2.5 years. I've even seen in the literature as long as 4 years of age, but that is an exception. So we want to wait until the patients are at least 1 month corrected age. Remember, a lot of these are going to be preemies. If you can't wait, then I would recommend hospitalizing babies that are less than 1 month corrected age, because their glucose homeostasis is not well controlled at that time, and so they have a higher risk of hypoglycemia. So it's important to follow those babies in the hospital, make sure they tolerate the medication easily. So here are some examples of patients, and you can see they start the treatment. This patient started at 2 months of age, and within a short period of time you can see the improvement and the lightening of the lesion. I've seen this happen within a week, seeing some improvement in the lesion. Parents often have that question, how quickly are we going to see improvement? And it's actually rather quickly, and most of the patients honestly have responded very well to this treatment. Here's another case where, again, starting treatment with the ulceration, starting treatment a little bit late. We would have wanted to start a little bit earlier, but within 2 weeks you start to see that healing. And in on the far right there where you see the letter C, certainly much better. And here's another example of a good response by 4 months of age. And here's a patient with ongoing therapy, and I think combination therapy is important. This patient was getting some pulse dye laser in combination with the oral propranolol. Here's a baby showing you that rapid proliferation. And you can see here with this baby, the imaging was a little confounding. It looks like there's a defect in the bony calvarium, but this was an artifact. This baby was fine. And you can see here, after starting the propranolol, within 3 months, and this baby was started quite early, at 1 month corrected age, and at 3 months significantly improved, and even now currently recently saw her doing great. Here's a patient with combination therapy, a before and after picture with a significant improvement. Some of these ulcerate in spite of early intervention. The segmental lesions, like I mentioned, are more prone to ulceration. In spite of all of this, the patient had a good response in the end. And there's a lot that we can do for ulceration and scarring with different lasers. The Fraxel laser, for example, the pulse dye laser as well, helps with the scarring and the reconstruction there. Here's a patient undergoing therapy with a significant improvement. And here's a patient that, in spite of early intervention, ulcerated. These segmental lesions ulcerate quite quickly sometimes, and the propranolol can also expedite this ulceration. So in some cases you want to go very slowly in the titration of the propranolol, because it's so effective in expediting the involution that sometimes that results in further ulceration. And this patient's now getting combination lasers to deal with that scarring, and she had no functional deficits. And so here you can see an example of a patient. This was before the time of propranolol. I showed you this little baby with a little precursor lesion, just a faint pinkness on the glabella, rapid proliferation, and then involution over time with oral corticosteroids, intralesional corticosteroids, and pulse dye laser. So this was before the time of propranolol, but just to show you how these lesions can be treated effectively. And here's another example of a patient with a great clinical outcome. So it's important to intervene early. And again, this patient is just to point out that the pulse dye laser in and of itself helps to improve these lesions. I think by a process of apoptosis, there's some literature on this, so that this patient only received laser and had quite a dramatic improvement with just the pulse dye laser. And it also helps heal ulcerations. So we have a lot of therapy to offer our patients with hemangiomas. And the very, very superficial ones, which are just cosmetic, but I don't want to say just cosmetic because it's very important to a lot of families to have these lesions removed. But again, no functional impairment in this case. But with a few laser treatments, the lesion's completely resolved. Sometimes we have to work together with our colleagues in surgery because this ulceration created a cleft, a through and through cleft. So this patient had combination treatment with surgery, propranolol, and pulse dye laser with a very nice outcome. And here we have a patient with propranolol, but the lesion wasn't responding quickly enough, and we wanted to alleviate the weight on the eye, and the surgery, we worked together with surgery for this patient as well. And this patient had the propranolol, but the Nasal tip had already proliferated quite a bit, and remember that's a very delicate area, so plastic surgery was able to intervene and make the correction in that Cyrano deformity. And this is a patient that had some surgery, so again, multidisciplinary team approach to management of these lesions. So if you do no treatment, you'll have a lot of residual lesion left. You'll have telangiectasias, erythema, atrophic scars, anidoderma, which is that redundant fibrofatty residue, hypopigmentation, and you can end up with permanent disfigurement. So it's not the desired outcome. And here are some patients that were just, the hemangiomas just ran their course without good results. And the literature has shown that there are short-term and long-term psychological effects to both the children and their parents. So because hemangiomas, as I mentioned, are very visible, these kids have reactions. They can have negative reactions from strangers and a certain social stigmatization. They can become depressed, stressed, have a low self-esteem. So it's important to intervene early and not have these kind of emotional effects on the patient and also on the family, who may have difficulty attaching to the child. They may limit public activities because of all the strangers, people asking questions, maybe guilting the family, what are you doing about this? Families can become depressed as well. So it's really important to intervene early. I can't stress that enough. And here's some literature on the negative impact of patients that are not treated early. They have a decreased social initiative domain score compared to children who receive treatment. So in summary, vascular lesions appear and grow in the first month of life. They should be treated, they should be evaluated and treated early. It's imperative to institute treatment early, as I've mentioned throughout the talk. That leave it alone, it's going to go away, is no longer a widely accepted paradigm for treatment. We have a lot of good treatment available, so we want to intervene early with systemic therapy when you have function-threatening, life-threatening, disfiguring, psychosocially compromising, ulcerated or high risk of ulceration lesions. And there's a lot of treatments available, but widely accepted recommendation is to have a combination therapy with a multidisciplinary team approach with systemic, topical, laser, and surgical intervention. And these are clinical practice guidelines from Pediatrics 2019, so very, very current, that I recommend that you review. Thank you very much for watching Physicians Chat.